Good morning. I'm re-recording this morning's thyroid disorder lectures because of glitch with the recordings. So let's get started. Hormone regulation through the endocrine system is primarily controlled via the HP axis, the hypothalamus pituitary axis. In the HPA, the hypothalamus, located just above the brainstem, detects signals from the brain and from circulating hormone levels. If the hormone levels are too high or too low, the hypothalamus secretes regulatory hormones that act on the pituitary gland, which is directly located beneath the hypothalamus. When the pituitary gland detects hormones from the hypothalamus, it increases or decreases the secretion of additional hormones. The hormones secreted by the pituitary gland travel through the bloodstream to regulate multiple major endocrine glands, which in turn helps maintain homeostasis throughout the body. Today's lecture focuses on one of the major endocrine glands, the thyroid. The thyroid gland is a butterfly-shaped gland with two lobes that is located anterior to the upper part of the trachea and inferior to the larynx. The thyroid glands are integral to normal body functions. Cells within the follicles of the thyroid produce and secrete thyroid hormone, a general name for two similar hormones, T4 and T3. And you can actually see what T3 and T4, what their names are in the right-hand corner of this slide. The primary role of thyroid hormone in adults is to regulate metabolism. The release of thyroid hormones is under the control of the anterior pituitary gland, which secretes thyroid stimulating hormone, TSH, and that is dependent on an adequate supply of iodine and the hypothalamus, which secretes the thyroid releasing hormone, TRH. The thyroid, in addition to secreting T3 and T4, also secretes calcitonin, a hormone that decreases excessive levels of calcium in the blood. Sound familiar? Osteoporosis. Let's do a quick connection check. The release of the thyroid hormone is under control of the anterior pituitary gland, which secretes T, right? SH, which is that thyroid stimulating hormone, and the hypothalamus that secretes TRH, which is the thyroid releasing hormone. Let's begin by discussing hypothyroidism. Another name for hypothyroidism, or the hypothyroid state in adults, is sometimes called myxedema. When thyroid production decreases, the thyroid gland enlarges in a compensatory attempt to produce more hormones. The goiter that results is usually a simple or non-toxic form. The term myxedema reflects the characteristic accumulation of non-pitting edema in the connective tissues throughout the body. And you can see an example of that in the right-hand corner of this slide, the periorbital edema. The face of the patient with myxedema appears puffy, the tongue is enlarged, and the voice is hoarse. Hypothyroidism can be either primary or secondary. Primary hypothyroidism is more common, and it's caused by congenital defects in the gland. It can be caused by a loss of thyroid tissue following treatment of hyperthyroidism with surgery or radiation. It can be caused by anti-thyroid medications. Could be caused by thyroiditis, which is an inflammation of the thyroid, or endemic iodine deficiency. What does endemic mean? Endemic means it's endemic, or it's attached to a particular population. And an iodine deficiency that's endemic would be areas of the world where there's an inadequate supply of iodine in the food, so that they would have an endemic hypothyroidism for that region. Secondary hypothyroidism may result from pituitary TSH deficiency or peripheral resistance to TH. Women are affected 7 to 10 times more than men, and it occurs most often in women between the ages of 30 and 60, and the incidence increases with age. In the US, hypothyroidism is largely associated with autoimmune disease, thyroid surgery, or radioactive iodine therapy used in the treatment of hyperthyroidism. Hashimoto's thyroiditis is the most common type of autoimmune hypothyroidism caused by an autoimmune response that leads to the destruction of the thyroid gland. In this autoimmune disorder, antibodies develop that destroy thyroid tissue. Functional thyroid tissue is replaced with fibrous tissue, and TSH levels fall. In the early stages, decreasing levels of TSH cause the thyroid to enlarge in an attempt to compensate, causing that goiter. But as the disease progresses, the thyroid gland becomes smaller. Hypothyroidism can also be associated with iodine and tyrosine deficiencies because they are needed for the synthesis of thyroid hormone. This type of hypothyroidism is rare in the US because of the use of ionized salt in our diet. The hypometabolic state is characterized by decreased energy, increased sleep, fatigue, weight gain, decreased appetite, and a susceptibility to cold temperatures. Patients can develop myxema, a condition that is associated with a generalized non-pitting edema. Cardiac alterations result from decreased cardiac output. Decreased GI activity results in constipation and abdominal distension. Skin changes may result over time, secondary to cold intolerance, and a lack of sweating may leave the skin dry and coarse. Hair becomes thin and fragile, and hair loss occurs. The diagnosis of hypothyroidism is confirmed through analysis of laboratory data, including T3, T4, and TSH levels. If the etiology is the thyroid gland, the TSH level is elevated because of the feedback system caused by the low circulating levels of T3 and T4. In secondary or tertiary hypothyroidism, the TSH may be high or near normal because this disorder is a result of the anterior pituitary gland or the hypothalamus. Replacement of thyroid hormone is the primary treatment. The most prescribed medication is levothyroxine. and you may know that as Synthroid. This medication is started at a low dose and increased as needed to treat symptoms. Because thyroid hormone affects metabolism, the medication is taken in the morning. This replacement therapy is a lifelong regimen, and it is important for the patient to take this medication at the same time every day. It is also important for the patient to inform all healthcare providers of his or her history of hypothyroidism and the dosage of hormone replacement. In patients with a history of cardiovascular disease, the increases in dosage of levothyroxine are made very cautious. Subtle increases in cardiac rate and contractility, secondary to a medication, may lead to angina or congestive heart failure. During periods of stress, such as invasive procedures, an adjustment in thyroid medications may be indicated. In older patients, an age-related decrease in serum albumin and renal excretion can increase the amount of available drug and cause an exaggerated pharmacologic effect. Therefore, the older patient may require less thyroid medication than a younger patient. The most severe type of hypothyroidism is termed myxedema coma. Myxedema coma is a life-threatening complication of long-standing, untreated hypothyroidism, usually triggered by an acute illness or trauma. It is characterized by hypoxia and carbon dioxide retention, secondary to hypoventilation, fluid and electrolyte imbalances, and hypothermia. Because of significant decreases in cardiac function, the patient is bradycardic and hypotensive. Additionally, hypoglycemia and hyponatremia develop. Along with the significant hypothermia during times of crisis, patients are sensitive to sedatives, analgesics, and anesthesia because metabolism of these medications is significantly slowed, leading to an accumulation in the body. Definitive treatment for this crisis is aimed at replacing thyroid hormone and supportive measures. So let's do a little connection check here. The nurse correlates which clinical manifestation to the pathophysiology of hypothyroidism. So we're actually looking for one of the signs and symptoms of hypothyroidism. So would it be weight loss? In this case, with a slow metabolism, they'd have weight gain. Insomnia? No, they're very fatigued and tired because of that slow metabolism. Diarrhea? No, they would be constipated because of the slow GI motility. So the answer is cold intolerance. Some nursing considerations. A thyroid hormone deficit causes a reduction in cardiac output. Remember, metabolism is slowed. Fluid may accumulate in the pericardial sac. That's the sac that surrounds the heart. So you want to monitor cardiac output, meaning you want to monitor blood pressure, rate and rhythm of the apical and peripheral pulses. You want to monitor respiratory rate and breath sounds. You want to avoid chilling because chilling increases metabolic rate and puts undue increased stress on the heart. So what nursing actions could you take to prevent chilling? Well, you could get blankets, warm blankets, avoid drafts, increase the temperature of the room, and alternate periods of activity with periods of rest. With regards to preventing constipation, you can always encourage fluids. You want to get them up and moving so activity is tolerated, and include a very high fiber diet. Skin integrity is compromised related to that accumulation of fluid in the interstitial spaces, and the patient has dry, rough skin. A decreased peripheral circulation, decreased activity levels, and slow wound healing further increases the risk of skin integrity being compromised. So what do you want to do? Well, you could suggest that the patient take baths as necessary, so maybe not every day, but every other day. Use gentle motion when washing. Use alcohol-free oils and lotions. Prevent prolonged pressure. So for those patients that are bedridden, you want to turn every 2 hours. You want to limit the time for sitting. Shift their weight by using pillows. Monitor the skin for lesions or redness. And this concludes our lecture on hypothyroidism.